Hi, I'm Dr. Susan Loveall. Welcome to our symposium on parent-child interactions, implications for social communication intervention and treatment in Down syndrome. Down syndrome is the leading genetic cause of intellectual disability. Individuals with Down syndrome exhibit a unique social communication profile that includes both areas of strength and areas of difficulty. Caregivers are perhaps best positioned to support development across social communication skills because they can be trained and coached to provide consistent and natural learning environments that scaffold and maximize linguistic and social growth. Many language interventions involve parent-child interactions, but an important first step towards intervention is describing what happens during these interactions. This symposium will present current research on parent-child interactions in Down syndrome and how they may shape different social communication outcomes. The first presentation by Dr. Mattie examines joint engagement, an important precursor for successful social interactions and language development during mother-child play and how this relates to language development in toddlers with Down syndrome. The second presentation examines the home literacy and language environments of infants and toddlers with Down syndrome and how this impacts vocabulary development both concurrently and 6 months later. This project was my student's, Madison Doolin, but I will be presenting as she recently had her own baby who is now at home for her to read to. The third presentation by Dr. Marie Channell examines mother-child talk about mental states during shared book reading and its role in language and socio-emotional development in school-age children with Down syndrome. The final presentation by Dr. O'Toole is a systematic review of parent-child interventions to promote communication outcomes in children with Down syndrome from birth to 6 years. We will conclude with our discussant, Dr. Abbeduto. Together, these presentations provide an overview of parent-child interactions in Down syndrome and highlight the potential for parent-implemented interventions and treatments.
Hello, I'm Dr. Mattie, formerly Hahn, and I'm going to speak about joint engagement in early language in toddlers with Down syndrome. Joint engagement characterizes a child's engagement with a caregiver around an object during a social interaction. Joint engagement is often an intervention target due to its long-term effects on language outcomes. There is also a developmental progression to joint engagement. First, children use supported joint engagement, where caregivers provide scaffolding to support the child's shared engagement with an object. As children gain more skills, they begin to take an active role engaging with the caregiver and the object in coordinated joint engagement. Research on young children with Down syndrome indicates that they spend more time in supported versus coordinated joint engagement, but they show increasing skills in both areas as they age. The purpose of the current study was to expand our understanding of joint engagement and early language abilities in toddlers with Down syndrome. We asked, what engagement state are children with Down syndrome spending more time in at time 1 and time 2? And what is the relationship between joint engagement and language concurrently and predictively? Participants for our study were 15 infants and toddlers with Down syndrome. At time 1, children were between 11 and 24 months, and at time 2, they were between 16 and 38 months. Children's joint engagement was coded during a 15-minute free play with their mother, and it was coded for the child's amount of time spent in each engagement state. The engagement states that we coded were unengaged, where the child's not involved with people or objects, person, where they're engaged in a face-to-face interaction with their mother, object, where the child's engaged with an object by themselves, supported joint engagement, so where they're interacting with the same object but the child's not acknowledging the mother's participation. So for example, if they're playing with a puzzle, the mother may encourage them by saying, where does the piece go? But the child doesn't look to her, look at the piece, give a lot of sort of back and forth about that. However, they may put the piece in the spot. In coordinated joint engagement, the child and the mother are engaged with the same object, and the child is actively acknowledging the mother's participation. So back to our puzzle example, when she says, "Where does the piece go?" the child holds the piece up, looks at her, looks back at the piece, and is smiling, and then maybe goes and puts it in the spot. When we're looking at language outcomes, we're most interested in object-supported and coordinated joint engagement because during these interactions, there's opportunities for mothers to provide linguistic input that can support word learning. We also had 2 language measures. We used the Mullen Scales of Early Learning and the Vineland Adaptive Behavior Scales. We used raw scores for the receptive and expressive language measures of each. So moving to our results, looking at the time spent in engagement states, our results are consistent with previous studies of joint engagement in children with Down syndrome, indicating that they spent more time in supported joint engagement than other engagement states, and we see this at both time points. Further, the amount of time spent in supported versus coordinated joint engagement was significantly different at each time point, such that children were spending significantly more time in supported than coordinated joint engagement. Moving to our examination of the association with language abilities, first we looked concurrently. At time 1, object engagement was negatively correlated with receptive language abilities on the Mullen. Given that there is a developmental progression to engagement states, it's not surprising that children with lower language abilities spend more time in this state, as they may not yet be able to shift their attention to include others in their interests. As children age, those who continue to spend more time in object engagement have lower language scores on the Vineland. It is possible that by not moving into more supported and coordinated joint engagement interactions, they are missing opportunities for language learning. This possibility is further suggested by our findings that supported engagement at time 2, when children were older, does influence language abilities such that the use of supported joint engagement is concurrently related to higher expressive language scores on the Vineland. Looking predictively, we saw that coordinated joint engagement at time 1 and Mulligan expressive language scores at time 2 were negatively related. Although this finding may seem odd, it may represent how mothers and children are compensating for lower language abilities. That is, these children may have really strong joint attention abilities, leading to more instances of coordinated joint engagement that compensate for language difficulties. And at the same time, mothers may respond to their child's limited language by being very responsive, leading to more instances of coordinated joint engagement. Looking at the intervention implications of our findings, they really highlight the importance of teaching parents to be responsive during interactions with their child. So for example, if a child is engaged with a ball, their parent can join their attentional focus by pointing to it and saying, "That's a ball." This provides rich, clear linguistic input for the referent that follows the child's engagement. It sets up the opportunity to scaffold the interaction, leading to opportunities for the child to move into supported and coordinated joint engagement. And it provides the opportunity for the child to respond to the mother's communication bid, and again, setting up that dynamic reciprocal interaction for language learning. We would like to thank all of the families who've participated in this study, our research assistants at the University of Illinois and Mississippi, and our funders at the University of Illinois. Thank you.
I'm Susan Loveall, and I'm presenting on home literacy environments, shared book reading, and receptive vocabulary development in infants and toddlers with Down syndrome. The home literacy environment refers to the exposure and nature of literacy-related activities in the home, including providing children regular access to books and engaging in parent-child shared book reading. Rich HLEs, including interactive shared book reading, have a positive impact on children's language and literacy development. Despite the well-documented difficulties with speech and language in Down syndrome, there has been little research examining if and how HLEs and mother-child shared book reading impact outcomes for this population. The purpose of the current study was to describe the HLEs of infants and toddlers with Down syndrome and to examine their relation with early receptive vocabulary abilities. We had 3 research questions. 1. How do mothers of infants and toddlers with Down syndrome characterize their HLEs and their child's engagement during shared book reading activities? 2. What is the quality of a shared book reading activity between infants and toddlers with Down syndrome and their mothers? And 3. Do differences in the quality of HLEs, shared book reading, and the home language environment relate to receptive vocabulary concurrently and 6 months later? The current study used a within-group longitudinal design. At time 1, HLE, quality of a shared book reading activity, and the home language environment were assessed. These served as predictors of receptive vocabulary at time 1 and again at time 2, which took place 6 months later. Participants included infants and toddlers with Down syndrome and their mothers. At both time points, children were administered the Mullen Scales of Early Learning to assess overall development, and mothers completed the MacArthur-Bates Communicative Development Inventories. Total number of words from the CDI was our dependent variable and was used to represent the child's receptive vocabulary. At time 1, there were 13 dyads. Children ranged from 11 to 29 months of age, and 69% were male. At time 2, there were 9 dyads. Children ranged from 16 to 28 months, and 67% were male. All HLE measures were collected at time 1. Mothers completed our adapted HLE questionnaire. This included 13 questions about the exposure and nature of literacy-related activities in the home, and 8 questions about the child's engagement in shared book reading. Summed composite scores were created for both variables, with higher scores representing richer HLEs and greater child engagement. Together, the dyads completed a shared book reading task at home while the child was wearing a Lena Recorder DLP. For this task, they were instructed to read the book Dear Zoo during any normal reading time. This activity was transcribed in SALT and then coded to assess the quality of the shared book reading activity. As part of the larger study, children wore the Lena for a full day. Adult word count was automatically calculated by the Lena and used to represent the home language environment. The shared book reading activity was transcribed and coded for maternal communicative behaviors, including expansions, questions, labels, comments, and requests. The percentage of utterances that contained any of these was used to represent the quality of the shared book reading task. A higher percentage indicated greater quality. An expansion was any utterance that added grammatical or semantic information to a child's utterance. A question was any question that pertained to the story or task, but that was outside of the printed text. A label was any one-word name of a pictured agent or object in the story that followed a question or phrase, but that was not part of the text. A comment was any general comment that related to the shared book reading activity, but that again was not part of the printed text. And a request was any request by the mother for an imitation or sound effect. For research question 1, we asked, how do parents of infants and toddlers with Down syndrome characterize their HLEs? At time 1, all mothers reported that they had begun reading to their child between 0 and 12 months of age, and half reported having a designated reading time. Mothers also reported they had many books in the home, on average over 100 of both children and adult books. A majority of mothers reported that during shared book reading, they point out details from the story that are outside of the written text, that they relate story events to their child's everyday life, and that they ask questions about the story. We also asked parents of infants and toddlers to characterize their child's engagement during shared book reading activities. When reading, almost all mothers reported that their child grabs for or holds the book, turns pages, and points to pictures or words. Half reported that their child asks to read books and pretends to read stories in books. Research question 2 assessed the quality of a shared book reading activity. 12 participants completed the shared book reading task. All of those mothers used expansions. 11 of 12 used questions. 10 used labels, 8 used comments, and 3 used requests. You can also see here the mean percentage of utterances that contained each of these maternal communicative behaviors, the highest being labels and the lowest being comments. For research question 3, multiple linear regression was used to examine the contributions of the HLE, child engagement, quality of the shared book reading activity, and the home language environment to child receptive vocabulary. At time 1, the total variance explained by the model was 90%. Child engagement uniquely contributed 72% of the variance, and the home language environment contributed another 17%, though in the opposite direction than expected. HLE and quality of shared book reading were non-significant. At time 2, with only child engagement and the home language environment entered as predictors, the total variance explained by the model was 76%. Child engagement emerged as the strongest predictor, uniquely contributing 76% of the variance. The home language environment was non-significant. Mothers in the current study reported several activities that enriched the HLEs of their infants and toddlers, including providing regular access to books and using interactive shared book reading strategies. Results also suggest that child engagement in shared book reading and the home language environment are particularly important to receptive vocabulary development in Down syndrome. However, in our model, increased receptive vocabulary was inversely related to adult word count. It is possible that as children gain greater understanding of words, parents do not talk as much because they are not providing additional linguistic mapping to help their children learn. Taken together, our results suggest that clinicians working in early intervention should teach families of infants and toddlers with Down syndrome practical ways to embed literacy-related activities into their child's everyday experiences, as well as how to promote child engagement in shared book reading activities. To wrap up, we'd like to thank the families who participated. We would also like to thank Dr. Marie Channell for her guidance on transcription and Ms. Laura Emming for her help with transcription and coding. And of course, thank you to our funders at the University of Illinois.
This study examined maternal mental state language use during shared storybook reading with children who have Down syndrome. Mental state language includes references to one's own and other people's emotions, thoughts, intentions, or ideas. And in typical development, it's critical for perspective taking and social communicative development. Also, mental state language development is linked to emotion knowledge, which is the ability to recognize others' emotional expressions and the causes and consequences of emotion, and to perspective taking skills. We also know that in typical development, mental state language and emotion knowledge are both facilitated by caregiver talk about mental states during caregiver-child interactions, such as shared storybook reading. And a lot of this development happens during the early childhood and preschool years for typically developing children. In contrast, we don't know much at all about how it develops in children with Down syndrome, although there is initial evidence from my lab that it is delayed even into the school-age years. However, there are currently no evidence-based interventions regarding how best to support this area of development for this population. So the purpose of this study was to provide a starting point by testing whether caregiver input also plays a key role in mental state language development for children with Down syndrome. Specifically, we aimed to determine the role of maternal mental state language in children's emotion knowledge and mental state language development in a sample of school-age children with Down syndrome by testing a conceptual model of mediation from the literature on typical development to determine whether it can be applied to Down syndrome. And as you can see in the figure here, we tested whether there is an association between caregiver and child mental state language, and if this association was mediated by increasing children's emotion knowledge. And this was an exploratory study, cross-sectional in nature. So 33 mother-child dyads participated, all at a single time point. And children were 6 to 11 years old with a range of nonverbal IQs and expressive language skills. All children were required to be verbal and able to speak in at least 2 to 3 word phrases. To measure maternal mental state language use, we used a mother-child narrative task where mothers were given a wordless picture book from the Mercer-Mayer Frog series, and they were asked to read with their child just like they would at home. And then we recorded and transcribed their speech, and we computed the percentage of utterances spoken by the mothers that contained any references to mental states. For example, in this picture here, you can see a scene from one of the books. And if the mom said, "The lady screamed," she would receive credit for using the word screamed, which is a reference to an emotion behavior. And if she said, "The man didn't know the frog was in his cup," she would receive credit for using a cognitive mental state reference with the word know. We also measured children's mental state language from a similar task. Children told narratives in response to another wordless picture book activity with an examiner who provided minimal prompting and scaffolding. We recorded, transcribed, and coded children's narratives for mental state language, and then we computed a diversity score representing the total number of different mental state reference words used by the children. And you can see here that in both the moms and the children, there was a wide range of mental state language use. And in the children, mental state language was just starting to emerge, with some children not yet using any mental state terms in their stories. Finally, we measured emotion knowledge nonverbally. So children watched nonverbal videos of a child acting out different scenes and or making emotional expressions with his face, and then the participants had to indicate the emotion being represented through pointing and labeling. We used a bootstrapping method to test the proposed mediational model because it's recommended for smaller sample sizes. It doesn't assume a normal distribution of the indirect effect, and it's higher powered than the traditional Sobel test. And in the current study, we used 5,000 iterations to estimate the mediated effect, and then we built a confidence interval around that. So the 95% confidence interval did not cross zero, indicating a statistically significant mediational model. However, for ease of interpretation, we also ran a sensitivity analysis using the traditional Barron and Kinney method for testing mediation, reported here in this table. Results were consistent with bootstrapping, although some of the p-values fell within the marginally significant range, all less than 0.10, and that's to be expected given the small sample size. Also, most importantly, these results indicate full mediation, meaning that child emotion knowledge fully mediated the effect of maternal mental state language on child mental state language. So the coefficient estimating the effect of maternal mental state language was significant here in the first model. And then it dropped substantially from 0.32 to 0.07 and became non-significant once child emotion knowledge was added in the model. And child emotion knowledge was a significant factor. In conclusion, our results suggest similarities with typical development in that for children with Down syndrome, more mental state language is associated with more maternal mental state talk. And we think that's happening through the development of children's emotion knowledge. And importantly, this study provides evidence of this relationship applying to the school-age years for children with Down syndrome. Of course, these results are quite preliminary. All data were cross-sectional, so we cannot draw conclusions regarding causality, and we know that there could be some bidirectional associations. But regardless, the finding that maternal mental state talk during shared storybook reading with their children was related to child mental state talk on a separate narrative task is quite compelling. Furthermore, the association with child emotion knowledge, which was measured completely non-verbally, tells us that it's not all about language. Their socio-emotional development is also playing an important role here in mental state language development. And it's also connected to what mothers are doing during the shared storybook interaction. So finally, regardless of directionality of effects, we know that mental state language is delayed in school-age children with Down syndrome and in need of intervention. So these data provide guidance for future clinical research to explore. That caregiver-child shared storybook reading could be a fruitful avenue for intervention, even for children with Down syndrome who are school-age. And this is an age-appropriate activity, and in fact, it's one that caregivers have reported that they're already doing frequently with their school-age children with Down syndrome. So it seems like a prime opportunity to explore as we move forward. I'd like to take a quick moment to acknowledge the families who devoted their time to participate in this study, as well as funding sources and my amazing team of collaborators. It truly takes a village, so thank you.
Hi, my name is Dr. Ciara O'Toole and I'm a lecturer and a speech and language therapist in the Department of Speech and Hearing Sciences in University College Cork in Ireland. And today I'm going to talk about a Cochrane review we completed looking at parent-child interaction therapy for language and communication in children with Down syndrome. So we know that language development is a particular area of weakness for young children with Down syndrome, and they have language difficulties over and above what we might expect from their general cognitive profile. And we also know about the importance of parental responsivity and language input for all children with language disorders. And this has led to the development of a number of different types of interventions known under the umbrella term of parent-child interaction therapy. And the idea behind this intervention is what Roberts and colleagues call this cascading model, so that the clinician provides effective training, coaching and support to the parent so that the parent can implement language promotion strategies with a high level of accuracy, consistency and frequency, and this will result in improvements in the child's language outcome. But these interventions do involve considerable commitment and time from families, and so we really need to synthesize the evidence for their effectiveness. And we looked at a Cochrane review because they are internationally recognized as the highest standard in evidence-based healthcare resources. And the types of studies included in our review were randomized or quasi-randomized control trials. Again, the randomized control trial being the gold standard intervention design here. We included caregivers of children with Down syndrome, a preschool age, and we looked at all types of parent-child interaction therapy compared to either therapy as usual, no treatment, or clinician-implemented intervention. And the primary outcomes I'm going to be talking about today were we looked at expressive and receptive language, and secondarily, I'm going to talk about the outcomes for parental responsivity. So we searched 18 databases and trial registered in March 2016, and this was updated in January 2018. And following title and abstract screening, we found 56 full texts. Now, 53 of these were excluded for a variety of reasons. They weren't randomized control trials, or for many of them, they had destroyed the data, and so we couldn't access the data for children with Down syndrome. So we only ended up with 3 studies. So I'll go through these quite briefly. So first was Ciara and colleagues in '98, and that included 12 children with Down syndrome, and they had to have 10 single words or signs to be included. It was all mothers who took part, and they were middle-class families. So there were 6 in the intervention group, and the intervention group got the Hannon Parent program, It Takes 2 to Talk, which was adapted for focus stimulation. So they got 9 weekly 2.5-hour group sessions and 4 individual sessions. So about 26.5 hours of intervention in total. Parents also got to pick the target words or signs for their kids to work on. And the control group just got intervention as usual. The main findings were, well, the intervention group did not use more spoken words according to parental report on the MacArthur CDI, but they did use more of the target words that they had picked. Furthermore, mothers used target labels and focus stimulation techniques more often than the control group, but they didn't increase their rate of interaction or their language complexity. And then in 2013, we had a study in Turkey that looked at 15 children, again, all mothers and middle-class families involved. There was 7 in the intervention group, and they got responsive teaching, which was delivered for about 1.5 to 2 hours a week over 6 months, so about 48 hours of intervention. And they got their standard care, and the control group got the same standard care, which was a specialist intervention for 2 days a week. What they found was that the intervention group made greater increases in their language and interactive engagement, and the mothers made significantly greater increases in their responsiveness and affect, and decreased their directiveness. Finally, in 2013, we had a study by Kaiser and colleagues, and they included 18 children with Down syndrome in their study. The children had a mean length of utterance of between 1 and 2 words at the start of the intervention. It was mostly mothers, but there was one father in this study, and again, the parents were middle class. So the 8 children in the intervention group got individualized and enhanced milieu teaching was the intervention here. And so twice a week they were seen in a clinic where the clinician worked directly with the child, but also the parent observed with another clinician, was talked through what was happening, and then tried out the strategies themselves and were coached by the clinician. They were also seen weekly in their home. So it was about 19 hours of intervention in total. And the control group got the same twice weekly enhanced milieu teaching, but only delivered by a clinician. And what they found was that there was no difference in child receptive or expressive language, either immediately after the intervention or 6 and 12 months post. But those in the intervention group did have a higher use of utterances in trained activities, not untrained activities. The parents in the intervention group also used significantly more enhanced milieu teaching strategies, and this generally remains significant over time. So what we found is very limited evidence and very incomplete. There's only 3 small-scale studies involving 45 children, and they were generally of low quality. And what we found is really inconsistent findings for the effects on the children's language development. Really only one of the studies that had the most intervention showed an effect. However, we do see a consistent effect on changes in the parents in terms of their improved responsivity, language input. All of the studies had a high risk of bias for allocation concealment and blinding of outcome assessors. It's very difficult to blind the participants to the intervention. They know they're getting it, but you can blind the outcome assessors, and that wasn't always completed. So when we looked at the quality of the evidence, it's actually quite low, very low. So we have very little confidence in the outcomes, and really further research is really important. So we definitely need more well-designed either feasibility studies or full randomized control trials that are adequately powered. We definitely need more children in these interventions. The intervention has to be very detailed, ideally in a manual, so we can follow it and explicitly outlining the coaching strategies that were used. And Lieberman Betts talks about this type of, when you're training parents, that you need to look at the treatment fidelity in terms of implementation from the therapist, but also how the parent is doing the intervention. And these 2 factors need to be looked at in terms of dosage, adherence, quality, and participant responsiveness, both in terms of the therapist, but also in terms of the parent. So it's multifactorial. And a recent study by Anne Kaiser and her colleagues in Vanderbilt, and they used an intervention called JASPER, which is Joint Attention, Symbolic Play and Emotional Regulation, combined with enhanced milieu teaching, and an AAC intervention for children with Down syndrome. So it was specific to the phenotype of Down syndrome. It was 3 to 4 times a week for 4 months, so there was 48 sessions, and they did show an effect on the language development of the children, which was more or less maintained over time. But that was a high dose, so high frequency over 4 months. So we need to think about these things when we're looking at the intervention. So in terms of practice, well, we have insufficient evidence to determine the effects. That doesn't mean we have an evidence of no effect. We just have not enough evidence. So really for clinicians, I would say continue to use your expertise, their family preferences and best practice guidelines as to where you should be going with these interventions. Think about the culture and resources of the family. Can they take on this intervention at the time? It's really important that the intervention is individualized into the routines of that family. It's natural, it's a natural everyday activity, and the targets are individualized to that children. And really we need to look at longer interventions, I think, for this group. Again, Roberts and Kaiser found that these kids might require more intensive and longer term intervention to look to ensure improvements in their language and communication. And really, we need to this needs to be ongoing and maintained over time. So I just want to thank you, and that's all.